with this, I'd like to invite on stage Dr. Sri Ganesh, who's the founder and director at Netradhama, group of eye hospitals in Bangalore. And I'm sure most of us know of him and his innumerable innovations. But for those of you who don't, he has a history in decades of innovation, and I'm sure we'll get to hear some really good ones today. Thank you, sir.
Thank you, Samaresh, for inviting me to this very interesting session. I'll be speaking on how to innovate, how to go about innovating, and my ideas and thoughts, and some of my innovations and how I got the ideas. So how do you actually innovate? So usually there is a roadmap on going about innovations. First is you have a problem, so you identify the problem. That is basically your research question. And you want to solve the problem, so you get an idea. And you may get an idea anytime. Sometimes you kind of relate to things in daily life and you get the idea. So then you need to define the need for this innovation and understand the opportunity which is available. Then you go about inventing. Okay, there may be a design, development and testing phase where you actually kind of look at whether the idea is worth pursuing. And then there's a stage of implementation, which is basically the proof of concept and risk analysis stage. And then you go on to the prototype testing and the clinical trials, which prove that this idea works. And that's when you register your intellectual property by applying for patents, and then you can get funding, and then finally you can commercialize the product, and that is the innovation. So there is a difference from an idea to an innovation, because an idea is just in your mind, but innovation is the final product which you can commercialize. So let's look at some of my innovations, and this was actually an interesting I was thinking about capsulotomy, fixated lenses to avoid dysphotopsia and rotation, and I was driving my bike. I stopped my bike, put on the side stand, and then I had a eureka moment. Why not have a swivel haptic IOL where you have two swivels which can swivel over the anterior capsule and the capsulotomy. So I made an IOL with biotech, and then we have worldwide patents for this, and this is the latest iteration of it, which is a toric IOL. We had a lot of challenges on the way. We had PMMA haptic initially, and it was breaking when we loaded the lens. Then we got a new kind of a material for the swivel haptic, and this is the toric version. So you just swivel the haptics over the capsulotomy. It captures the capsulotomy, and then the lens is very stable. It's more anterior, the ELP, and you get a perfect alignment. There's no rotation. There's no dysphotopsia. This is one of the cases. So we have also had a publication, our initial clinical trials, and now we have worldwide patents, and we just got the approval for multicentric trials. And once we do the multicentric trials and then commercialize it, then we hope that it will be available in a couple of years. So it's, once you start with an idea like this, it takes maybe like a decade before it can mature. Then you can have simpler ideas. See, when you are implanting a toric IOL in a small pupil, it's very difficult to know the axis. So you may have to retract the iris, look at the axis, and then you're still not sure at end of the surgery whether it's placed on axis. And retracting the iris causes release of iris pigments, prostaglandin release, can lead to post-op uveitis, IOP spikes, cystoid macular edema. These are all issues. So I was thinking how we can kind of solve this problem, and then I was looking at toric IOLs and breaking my head because most of the Indian pupils are small. Then I was at the gym working out, and then I just put down that weight on the bench, and then when I lifted the weight, I saw the indentation mark there, which kind of disappeared after some time, and then I had my eureka moment, and then I knew I had kind of solved this problem. So I made a toric marker, the GANESH toric marker, which has two windows to see where you're marking, and then you can make a temporary mark on the center of the lens, and then implant it, and then it's very easy to align it even if you don't see the peripheral marks. So this is the Ganesh toric marker from Epsilon, and then you can just, you see you have this indentation there. This is on a J&J lens. You place it, and then you can see it very clearly. Even if the ink disappears, you can see the mark, you can see the indentation because of the reflection of light. So you can't see the peripheral marks at all, but you know the central mark is there, and then after some time it disappears. And first day, post-op day, we have also looked at scatter, we have looked at the OSI, and the lens is perfectly normal. So it's a temporary mark for placement which lasts, it remains for about 2 to 5 minutes, and then it disappears. Enough time to kind of align your lens. So it's a very simple idea, and it works. And this is something that the idea from, your day-to-day activities, and then you suddenly get an idea. So you have to relate. Necessity is the mother of invention. So when you have a problem, then you're thinking about it all the time, then you kind of get an idea. So this was a cystotome maker, the Ganesh Grewal cystotome maker. So our assistants keep bending and making the cystotome, but sometimes you have multiple assistants in different ORs, and each one is bending the cystotome in a different way. So there is no standardization, and then it's frustrating because your rexis, you may not get a good rexis because the cystotome is not okay. And the Alcon cystotomes are very expensive. So I thought, okay, we'll make a cystotome, we can have a cystotome maker, which is very easy for the assistants, and which gives you a very standard cystotome. So this is the cystotome maker, and this is, we made it like pliers, and this is how it acts. So you have a small indentation for the hub there where you can place it, and then you have a block which actually bends the tip of the needle, and then so this is how it works. This is a 26 gauge needle, you just place it there, this is a BD needle, and then you just crimp, you press the pliers, and then you can see that the tip of the needle is bent exactly. So you don't have to use a needle holder, it doesn't damage your needle holders, and then you kind of just get the perfect angulation. So that is how you make the cystotome, and we got these dimensions from the Alcon cystotome. And so you get an exact reproducible cystotome every time, irrespective of the assistant, and then you can make a very nice capsulorhexis. So you have the exact bend, you don't have too long a bend in the needle, so this kind of solved that problem. And surgery is all about standardization. So if you have standard techniques, if you have standard instruments, then you get standard results. So this is how the cystotome maker works to give you perfect cystotomes for your surgery. And this is available from Epsilon. So that's one of the ideas there. Then sometimes a colleague comes to you with a problem. So we have a training program. Many of the fellows have PCRs during phaco, and then you have fragments left in the chamber, and if they go after these fragments, then you have a nucleus drop. So the safety net device is a temporary rescue device, and this is something that we made with biotech. So it is, you have version 1, version 2. It's like a grate, which is circular. Overall diameter is 7.5 millimeter. It's made of a foldable hydrophilic acrylic material, which you can just place under the fragments and then safely remove the fragments. And oops, sorry, let me play the video. So then I kind of designed this, and then biotech made it for us, and we'll show you this device in action. So you can see that there's a PCR and a very large piece. So if you go after that, then you're going to be in trouble. So you just put in visco. If required, you can do a limited anterior vitrectomy, and then you make the side ports there. Put in this device, inject it in front of the iris. It opens up like a grate, and then you can use the iris, you have your iris hooks, so you can kind of hook it up with the iris hook so that it is stable. It does not change the plane, nor does it dislocate into the vitreous, and then you have a very stable platform where you can safely go in and do phaco and remove this fragment. So you don't have to convert into an SICS, because most of the fellows convert to an SICS when they have this. So you can still maintain the small incision. Then you can remove this. This is a temporary device. You just have to pull it out with forceps. Comes out very easily. Then you can do your bimanual IA and your vitrectomy. You can see that's a very large PCR, but that's anterior vitrectomy being done. And then you can place the lens, three-piece lens in the sulcus and do an optic capture. So you can kind of save the day with this. There are many other innovations. Also described a technique called lenticuloschisis, which is a no dissection technique for lenticule extraction in SMILE. It's published in the JRS. Also, we described using SMILE lenticules to treat hyperopia, called it FILI, femtosecond intrastromal lenticule implantation. We published a 5-year follow-up, and manual cyclotorsion for SMILE, viscochop for femtocataract, and also some SMILE instruments. So coming to research, research is a frame of mind. So if you're always thinking about the problem, you get an idea, then you can pursue it and then innovate. So you don't need big laboratories, you don't need expensive equipment. So it's all in the mind, and this is what I would like to convey. This is just telling you about APA-CRS, the 37th APA-CRS in Ahmedabad in August. So please register and come for this meeting. Thank you very much for your attention.
Thanks a lot, sir. I think you have a couple of questions coming up here. Mic on.
Yeah, superb innovations, just brilliant. But one thing I have noticed, I've also made small innovations, not so good, but whenever we are more relaxed, one has to have like the frame of mind that you have, then the innovations come. If you see, Newton was sitting under an apple tree. If you see, Archimedes was in a bathtub. If we see, Pythagoras was just staring at a floor. And even the...
And I was riding my motorcycle.
Motorcycle. So that's being in a very relaxed state of mind and not actually overthinking all the time. And even Buddha got enlightenment under a tree. And all the examples, even the theory of relativity of Einstein, he was resting. Many come when you're taking a nap at night. And I would also suggest whenever you get an idea, just open your iPhone and jot it down, because somehow by morning it's just evaporated. So that's all.
Yeah, you can jot it down sometimes on napkins when you're having dinner.
Exactly, exactly.
All sorts of things happen on your phone,
yeah.
Whatever piece of paper you get.
Absolutely. So. Because many times if that moment's gone,
yes.
Then to get it back again, you'll scratch your head and you'll not be able to think what it was again. That's all.
So it's a frame of mind. So you and you have to be calm.
You have to be very calm and a relaxed person in general to be able to think. So, but this is a very good trait, because I guess, you are doing a lot of work also at the same time to be like that. They're very paradoxical situations. Yeah. Thank you.
Thank you.
Sir, every time I look at all these, I really get so inspired. So thank you for keeping stimulating us. I just have always thought of one thing. So with that, the swivel haptic.
Yes.
Is there a difference in the PCO because you are clipping the
We did, see, the thing is we also were concerned, because we thought there's going to be a space because it's more anterior, but what happens is the PC actually comes up. In about 3 weeks, you have the shrink wrap effect. So even if you leave a patient aphakic, there's fusion of the anterior and posterior capsule. You see that the posterior capsule actually comes up. It's not convex. So we did UBM in these patients, and we see that the PC comes up, and it's got a 360-degree square edge. So a PCO is not higher in these lenses than the regular lenses. We were also worried about, okay, if the swivel haptics, they rub against the undersurface of the iris, will there be pigment release? So we also did gonioscopy to look at the pigments pre-op and then post-op, but there was no increase in the pigmentation and there's no higher incidence of uveitis or anything like that. And now it's been like, since the first lenses we implanted almost 8 years and these patients are still doing well.
Thank you, sir.
Also, sir, one last question on the Rexis, the cystodome bending. So it's a brilliant idea, especially for fellows because they sometimes can't make the right ones and they overbend.
Yeah.
The needle tips are standardized, or not all companies will make the same
See,
needles.
this is with the BD company and it's pretty standardized. So if you're using any other company, most of us I think use BD needles for cystodome. These are the insulin needles. If you're using different companies with different lengths, then you have to use the half-inch one only. So if you're using a different company, different length of needle, then it may not work.
Thanks a lot, sir. Thank you so much.
Thank you.